Okay, so we're starting the live stream in 1, 2, go. All right. Good evening, guys, and welcome to today's discussion. As usual, we'll be taking questions one by one and then trying to find the solutions. Okay. And I'll try and be sharing my screen so you guys can follow me.
Okay, thank you so much.
So Asma, you're welcome. Timmy, you're welcome. Okay, so let me post some questions. The other day we discussed von Gecker. We discussed some biochemistry questions, liposomal storage disease, which I put some of the pictures in the group. Von Gecker disease, that which is a glycogen storage disease, porphyrias, narcolepsy. Well, like which area of the brain is affected by narcolepsy? Is the hypothalamus, by the way. Okay, so let me look for a question. The question is about causes of hyperprolactinemia. Except a chronic Have you guys attempted the question?
Okay.
Someone said A, except A, right? So that means someone said D. Sorry again. Yvonne, are you changing your mind?
Yes.
Okay. Well, I'm going to show you something. Look at some of the causes of hyperprolactinemia. You know, prolactin is what's prolactin? The hormone of where?
Okay.
Is it
It's anterior pituitary gland.
the posterior?
No, it's
All right, so it's the hormone of the anterior pituitary gland. So that already gives you an idea of
Oh, okay. I think
an
I should.
idea of some of the causes. So on the screen, then yeah, anterior pituitary, of course. So it's stimulated by prolactin inhibitory hormone. It's controlled by the effects of prolactin inhibitory hormone from the hypothalamus, right? So self talking about when you talk about lactose, you're essentially talking about breast milk, right? So prolactin stimulates the growth of production of breast milk, right? And it's a very important hormone because it's stimulated released during breastfeeding. Okay, so physiologic causes of hyperprolactinemia. Physiologic, we have pregnancy, of course, pregnancy, preparing the mother for breastfeeding, right? Then nursing mothers, of course, breastfeeding mothers. Nipple stimulation will increase will increase prolactin um, levels. Exercise, stress, sleep, seizures will increase prolactin levels. And of course, pharmacologic. And we know that prolactin inhibitory hormone, another name for prolactin inhibitory hormone is dopamine. All right. So all these antipsychotic agents that inhibit dopamine release are indirectly inhibiting the inhibitory effect of prolactin inhibiting hormone. I don't know how to explain it, but just another prolactin inhibiting hormone is dopamine. So if you have a hormone that is inhibiting dopamine, that's inhibiting the inhibitory effect of prolactin inhibiting hormone, that means you double negative is positive, right? It means you have hyperprolactinemia because there's no more hormone that will inhibit it. So dopamine antagonists like methyl dopa, all those drugs, all right, they have effects. Monoamine oxidase inhibitors, and of course, one of the non-antipsychotic drugs that affect prolactin levels is cimetidine. That's H2 receptor antagonists. Okay, that is used for peptic ulcer disease. All right. Then verapamil, thyrotropin stimulating hormone. All right. So then pathologic ones, I think this is where the question is coming from. All right. There's pituitary tumor, pituitary prolactinoma. Of course, when we know that prolactin is produced from where the anterior pituitary gland. So if you have a pituitary tumor, it means there could be overgrowth of the part that secretes the cells that secrete prolactin, and you could have prolactinomas that will keep releasing prolactin, right? Then despite the inhibitory hormone, all right, from hypothalamus, right? And hypothyroidism, hypophyseal stalk lesions, of course, brain lesions like spinal cord lesions, and hypothalamus inflammation. So yeah, we could go with none of the above, okay, concerning that. But if you want to choose the best option, you can go with chronic renal disease. If you want to choose the best option, even though we know that chronic renal disease can cause hyperprolactinemia. Okay, when the kidneys are not working well, you cannot excrete the prolactin, you cannot excrete many of the hormones, you cannot excrete drugs, you cannot excrete toxins. The same thing, that the liver is involved with detoxifying drugs. Okay, so detoxifying drugs, toxins, and all those stuff. So both of them can worsen the situation. Okay, so S protein. So when someone has hyperprolactinemia, what do you expect clinically? What do you expect? What do you think you should expect? Yeah, gynecomastia. Thank you. Galactoria, like and of course, yeah, infertility too. Okay, so galactoria and infertility. If you have a patient that has adenoma and the person has infertility, think of hyperprolactinemia. All right, and of course, you take a history of galactoria, gynecomastia in males, galactoria in females and males. Okay, expressible galactoria. That's the word actually. Expressible. That means you know yeah, those ones in addition can have headaches. That tells you that there's, the pituitary gland is at the middle. Let me show you. Let me show you a picture. Is where the optic chiasma is. Okay, you know where the optic chiasma is in the brain. You know how the visual pathway is. All right, pituitary gland and optic chiasma. And we know that anything that affects the optic chiasma will cause bitemporal hemianopia. So let me show you. Yeah, this is a nice image. This one. Okay. You look, you would see that still it has loaded. You will see that look at the pituitary, look at the eyes, okay, the globe and the pituitary optic nerve, all right, then optic chiasma, optic tracts, optic radiation, and all that, all the way to the optic optic what do you call it? Okay, so you can see a pituitary tumor that is growing here, that is impinging on the optic chiasma. Okay, so naturally you expect that as it's impinging on the optic chiasma, it will prevent some impulses from flowing to the brain, to the occipital lobe, where visual field, visual visual cortex is. All right, so you now have bitemporal hemianopia. So that's that about that. Okay, next question. Do you have any question on that? I don't think so. Um, question is about So the question is about sorbitol. I will share something with you. Make your attempts. People are saying E. Why are you saying E? The answer is staring you in the face. You are saying E. Okay, so sorbitol is a sugar alcohol with I think they use it for some of these products when they want something to be sweet, right? And it's gotten from glucose. So there's a very pertinent reaction. It's kind of like mixing glucose with alcohol. So they call it sugar alcohol. Has a sweet taste and metabolizes very slowly in the human body, obtained by reduction of glucose. Okay, let's see. It is converted to fructose by sorbitol 6-phosphate dehydrogenase. So sorbitol is an isomer of mannitol. You know mannitol now. Now what's mannitol? We use it for raised intracranial pressure. It's an osmotic diuretic, right? So sorbitol is synthesized via a glucose reduction reaction, all right? Reaction requires NADPH and is catalyzed by aldolase diarrhea. Is actually this sorbitol and ice creams. That sweet taste of ice cream is sorbitol. So the enzyme is called aldolase reductase enzyme. Okay. One thing about West Africa is that their question can be weird sometimes. They ask, they ask a lot of weird questions, but the thing is there's no negative marking. So because there's no negative marking, even if they ask you weird questions, you know, you'll pass. You'll pass. All right. And they will ask you a lot of things that you're familiar with. Okay. Let's say 70% of the questions are things that you can just answer even when you're sleepy. Okay. Then I'm trying to pick some of the weirder questions so that you see how far they can go. But most of the questions are things that you can answer. Okay. If you have been following the discussions, you have been reading, you are good to go. You look at the discussion, the update slides, right? You are good to go. But you still have to know of these other questions that maybe generally, if you are reading, you may the answer is none of the above anyway. It's frozen. Can you see? Can you hear me? Can you guys hear me? Am I being heard? All right. So I'm posting the next question. The next question is about causes of elevated troponins. All right. So there it is. Causes of increased troponin except A, myocardial infarction, B, pneumothorax, C, pulmonary embolism, D, normal variants, E, subarachnoid hemorrhage. You guys are choosing subarachnoid hemorrhage. Shock now. Shock now. Subarachnoid hemorrhage is the cause of raised troponin. Can you hear me? Can you guys hear me? How did you know? I was saying. Can you hear me now? All right. So the question is about causes of elevated cardiac troponins. So there are some causes shown on the screen. There's the cardiac causes and the non-cardiac causes. Let me still be in the question in the future references. There's cardiac condition. See that the first one is myocardial variants of the heart. You can see a list of causes here: cardiac surgery, cardioversion, electromyocardial biopsy, of course, chronic heart failure, acute and chronic heart failure, aortic valve, cardiac muscle. That's number one. Two, diseases of the cardiac, the pericardium. Okay. Then even diseases of the endocardium too, endocarditis can cause it. So you have myocarditis, endocarditis, pericarditis, rhabdomyolysis, post percutaneous coronary intervention, cardiac surgery, cardiac biopsy, left ventricular hypertrophy, cardiomyopathies, tachyarrhythmias, bradyarrhythmias, heart block. Okay, all these can cause it. These are from the heart, diseases of the heart. Then diseases that are not from the heart, pulmonary embolism is there. Okay, let's say diseases are not from the heart, from the chest, the lungs. You can have pulmonary embolism. You can have pericarditis. Not offline. How am I going to solve this person's issue now? If you're not able to log in, it's not from my end. People are logged in. All right. Somebody, please just help me explain to him. Maybe my and open it. It's still showing pituitary. No, now. Streaming the causes of pericarditis. I'm able to talk, you're able to hear me. I will not have that liberty of doing that within the group. So there are so many advantages. I'm even able to stream. I'm even able to share my screen and then show you some things that I need to explain that I will not be able to type. It's just, we will achieve more here. Okay. So that's that. Please mute your mic for you. Okay, so the last question was about causes of increased Dr. Yvonne, please mute your mic. Last question was about the causes of increased troponin, thorax, pneumothorax, pulmonary embolism, and normal variants. Okay, so subarachnoid hemorrhage as well. I was showing you guys my screen, which was showing. That was the screen you guys say you were not seeing. That's why I had to log off. Let me share it again. Believe you can see it now. That's my screen. Plasma cardiac troop, acute coronary syndrome, and what else? All those causes of acute coronary syndrome. Will lead to elevated cardiac and non-cardiac causes. So even strokes like subarachnoid. The only odd one out there is pneumonia. Please read it though. And you know, the last time we spoke, I gave you guys a code. It's there in the chat. You know, VP-CAM, okay. Von Gecker is type 1, GSD. P is for Pompe. Pompe is type 2. A is for Anne. All of the following are a lot of biochemistry questions. All of the following are 6 carbon following are 6 carbon monosaccharides, except 1, A, xylose, B, mannose, C, galactose, D, glucose, mannose, which became yeah, A. Is anybody confused about why it is A? It's working. Your chat box is working, Chibike. You press enter to send. It's working. Okay. So, yeah, it is xylose. The other ones are simple sugars now. Glucose, fructose, galactose, mannose. They're just like simple sugars. But let's look at monosaccharides. Yeah. Common examples of simple sugars or monosaccharides are glucose and fructose. Both of these monosaccharides are known as hexoses since they have 6 carbons. Okay. Let me look at so they are known as simple sugars. The main monosaccharides are the hexoses. Okay, simple sugars, fructose, galactose, and mannose. Yeah, that's. I'll look at how many. Monomer of glucose is dextrose. Monomer of fructose is levulose. Okay, so let's look at how many carbons the xylose has. 5. Wow. Xylose is a monosaccharide of the aldopentose type, consists of 5 carbon atoms and an aldehyde functional group. So there you have it as your answer. No, 5. I just showed you the answer now. It's 5 carbons with an aldehyde group. All right. Okay, so I'll go to the next question. Okay, so this question is about hypoxia. Hypoxia and how it stimulates hypoxia and how it stimulates increased respiratory drive. We know that hypoxia stimulates increased respiratory drive. So how does it do that? We know that baroreceptors, of course, are for blood pressure maintenance. So that one is out of it. So what are J receptors? J receptors are known as juxtal capillary receptors, pulmonary C fibers, are sensory nerve endings located within the alveolar walls, okay, in the pulmonary capillaries. What do they do? The functional role is unclear, but the response to pulmonary edema, pulmonary emboli, pneumonia, congestive heart failure, barotrauma, which cause decrease in oxygenation and thus lead to an increase in respiration. They may also be stimulated by hyperinflation of the lung, as well as intravenous or intracardiac administration of chemicals like capsaicin. The stimulation of J receptors will cause a reflex increase in breathing rate, respiratory rate. So they are involved in dyspnea. So when you see a patient that is having dyspnea, think of their J receptors being stimulated. Okay. So hypoxia is likely going to stimulate the aortic carotid body. Small cluster of cells, chemoreceptor cells, found in the, of course, in the common Okay. So should I write on? I believe you guys can hear me. Still hearing me? Chibike has finally figured it out. You're welcome, Chibike. Finally. All right. Let me tell you guys something. There's something about West Africa too. It's the way they ask their questions. Okay? This is a chest X-ray showing pulmonary infiltrates, opacities. This is more like a homogeneous opacity. On the right middle lung zone. So there are common ways of classifying pneumonia by location. All right, you can say community acquired, hospital acquired. Okay, there's even ventilator associated. Okay, then so hospital acquired, you can have ventilator. Okay, then by cause, you now start talking about each of the organisms and different things that they can do. All right. So there's something about the way West Africa asks their questions. And ask you a question without mentioning, putting an except, like expecting you to pick the odd one out. Like if you have multiple answers that are pointing towards the question, you should choose the odd one out. Okay. And usually where they mention multi-drug resistance is in like TB. Okay. So multi-drug resistant TB, something of that nature. Okay, so Asma, you are correct. If you looked at the questions in the app, I mentioned it was mentioned there that West Africa, one of the things that they do is to ask questions. They may not put an except, or they may expect you to pick an except somewhere. All right. So just keep that in mind. When they ask you a question, you should ask yourself, what are they looking for? Are they looking for the the course is the best option exam. Okay, so the question is more like okay, the option C was just vitamin. Okay, yeah. So the vitamin that requires zinc for its all right. Yeah, zinc is an important coenzyme. The question is sort of difficult to articulate. But see, we have vitamin B12 and B6 require zinc. I'm not sure about vitamin A. I'm not sure about vitamin E. What do you use spirometry for, guys? How do you use spirometry? Okay. Able to answer that, that will lead us to this next question about restrictive lung diseases. Spirometry, is it for lung function? Spirometry is different from lung function test. Spirometer is that thing you use for asthma. That thing you blow inside. Okay. Spirometry is supposed to tell you the only thing that spirometry measures is the FVC and FEV1. So with spirometry, you're supposed to be able to compare the first expiratory volume in 1 second. You're comparing it with the first vital capacity. Okay. And based on what you get, you'll be able to make an inference of what type of lung disease it is. Okay, broadly speaking, you can say it's a lung function test, but this is the specific reason why you are using it to classify lung diseases into constrictive and restrictive. Okay, so sorry, obstructive and restrictive. Okay, so the obstructive lung disease like COPD, asthma, then restrictive lung disease like, you now tell me the answer. So which of these is a restrictive lung disease? So answer this question, guys. Restrictive lung disease. Which of these is a restrictive lung disease? A, bronchiectasis. These are not be true or false question. Now they don't ask true or false question anymore. Dr. Yvonne. It's just straightforward. It's best option. Single answer. Okay. So this one are telling me true, false, or false, true. Dr. Praise thinks it's A. Thinks it's D. Sarcoidosis, bronchiectasis. Dr. Yvonne, you have switched. This is the total opposite of what you said the first time. You said A the first time. Now you're saying sarcoidosis. All right. So let's take a look at it. Let's watch something together.
Hey guys, it's mcqs Perfectionalis, where medicine makes perfect sense. Today we'll continue our discussion about pulmonary medicine. In previous videos we have talked about obstructive lung diseases. Today we have an introduction about restrictive lung diseases. If you get this introduction and lay this foundation, it's gonna be a piece of cake. Restrictive lung disease. My lungs are restricted from filling. I cannot get the air in. Symptoms: cough and dyspnea, also known as SOB, which stands for shorts of breath because I do not curse. I'm a good guy. With that being said, now let's get started. I have never met a medical student in my life who said, "Oh, I love those restrictive lung disease. This is my favorite subject to study." Said no student ever. The secret of getting ahead is getting started. Just one by one, step by step, you will get better and better and better. And as Beverly Sells said, there are no shortcuts to any place worth going. It's gonna be tough, but you can do it. Lung diseases are divided into obstructive and restrictive lung diseases. Obstructive, I cannot get the air out. Restrictive, I cannot get the air in. Obstructive include asthma, chronic bronchitis, emphysema, bronchiectasis, bronchiolitis. Restrictive include any disease that ends in osis and related to the lung. Don't say mcqs is irrestrictive. No. It's not a restrictive lung disease. Hey guys, it's mcqs Perfectionalis, where medicine makes perfect sense. Today we'll continue our discussion about pulmonary medicine. In previous videos we have talked...
Put off your this thing now. Who's making this noise? Mute yourself.
About obstructive lung diseases. Today we have an introduction about restrictive lung diseases. If you get this introduction and lay this foundation, it's gonna be a piece of cake. Restrictive lung disease. My lungs are restricted from filling. I cannot get the air in. Symptoms: cough and dyspnea, also known as SOB, which stands for shorts of breath because lung disease. My lungs are restricted from filling. I cannot get the air in. Symptoms: cough and dyspnea, also known as SOB, which stands for shorts of breath because I do not curse. I'm a good guy. With that being said, now let's get started. I have never met a medical student in my life who said, "Oh, I love those and better." And as Beverly Sells said, there are no shortcuts to any place worth going. It's gonna be tough, but you can do it. Lung diseases are divided into obstructive and restrictive lung diseases. Obstructive, I cannot get the air out. Restrictive, I cannot get the air in. Obstructive include asthma, chronic bronchitis, emphysema, bronchiectasis, bronchiolitis. Restrictive include any disease that ends in osis and related to the lung. Don't say mcqs is irrestrictive. No. It's not a restrictive lung disease. It's a beautiful medical channel. But here you have coal workers' pneumoconiosis, asbestosis, silicosis, berylliosis, sarcoidosis, you name it. This slide summarizes all of pulmonary medicine in just one sentence. Cough and or dyspnea equals one of 5 categories. Here are your choices, baby. Obstructive lung disease, restrictive lung disease, pulmonary vascular abnormalities, infection, malignancy. That's it. Obstructive lung disease include asthma, chronic bronchitis, emphysema, bronchiectasis, bronchiolitis. Chronic bronchitis and emphysema together are called COPD. Restrictive lung disease could be parenchymal, which means the disease is in the lung itself. Pleural, it's in the pleura or chest wall. Neuromuscular, or even in the abdomen, such as ascites, or organomegaly, such as hepatomegaly or splenomegaly. Okay, parenchymal such as what? Interstitial pulmonary fibrosis, or idiopathic pulmonary fibrosis. Idiopathic has ascites or organomegaly fibrosis. Idiopathic means we have an unknown cause. We have also pneumoconioses, sarcoidosis, and even systemic sclerosis or scleroderma or rheumatoid arthritis, respiratory bronchiolitis associated interstitial lung disease, and this is associated with smoking. Don't ever forget that. So smoking can lead to an obstructive lung disease such as COPD, or a restrictive lung disease such as respiratory bronchiolitis associated interstitial lung disease. If you want to know more about bronchiolitis, watch my previous video in this playlist. Plural such as pleural effusion or pleural thickening, chest wall kyphosis, scoliosis, kyphoscoliosis, ankylosing spondylitis, pectus excavatum, pectus carneatum, etc. Neuromuscular myasthenia gravis, Lambert-Eaton myasthenic syndrome, Guillain-Barré, post-polio syndrome, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, and abdomen, as you know. Pulmonary vascular abnormalities include pulmonary embolism, very important and very dangerous, pulmonary artery hypertension, pulmonary veno-occlusive disease, and even vascular abnormalities include infections, include pneumonia, big time, TB, oh no, bronchitis, especially acute bronchitis, and tracheitis, and also in kids, croup, laryngotracheobronchitis. Malignancy such as bronchogenic carcinoma, where it arises from the bronchi or bronchioles like this, alveolar cell cancer, where it is in the alveoli, or metastasis, which is by far the most common lung cancer, is a metastasis because all of the circulation goes to the lung. That's the job of the right side of the heart. Restrictive lung disease, what's the definition? I cannot get the air in. My lungs are restricted from filling. Same thing as restrictive cardiomyopathy of the heart. Restrictive lung disease, what's the definition? I cannot get the air in. My lungs are restricted from filling. Same thing as restrictive cardiomyopathy. My heart cannot get the blood in. It's restricted from filling. Cardiomyopathy. My heart cannot get the blood in. It's restricted from filling. You have decreased in all lung volumes and capacities. No wonder, because you cannot get the air in. FEV1 FVC rate from filling. You have decreased in all lung volumes and capacities. No wonder, because you cannot get the air in. FEV1 FVC ratio could be normal or increased. This is how you diagnose restrictive lung disease. This is step number 1. Step number 2 is how to determine you cannot get the air in. FEV1 FVC ratio could be normal or increased. This is by looking at the total lung capacity. The lower the TLC, the more severe the restrictive lung disease. Two types of restrictive lung disease: extrinsic, which is not the lung's fault, and intrinsic, which is the lung's fault. Extrinsic, the problem could be in the chest wall, neuromuscular, diaphragm, pleura, or even the abdomen. Intrinsic could be problem in the lung, could be interstitial or alveolar. Interstitial means, okay, here is your lung, and here is your alveolus, and another alveolus. Between them, there is connective tissue, interstitial space. So interstitial lung disease is here, which is not the lung's fault, and intrinsic, which is the lung's fault. Extrinsic, the problem could be in the chest wall, neuromuscular, diaphragm, pleura, or even the abdomen. Intrinsic could be problem in the lung, could be interstitial or alveolar. Interstitial means, okay, here is your lung, and here is your alveolus, and another alveolus. Between them, there is connective tissue, interstitial space. So interstitial lung disease is here. Alveolar restrictive lung disease is in the alveolus, such as a famous or not so famous disease called alveolar proteinosis. Can you give me an example of an interstitial lung disease? Yes, interstitial pulmonary fibrosis. How many obstructive lung diseases are there? 5. Asthma, chronic bronchitis, emphysema, bronchiectasis, bronchiolitis. How many restrictive lung diseases are there? More than 100. So are you going to discuss all of them? No, I have a life. Abraham Lincoln said, if I had 4 hours to chop down a tree, I would spend the first 2 hours sharpening the axe. That's why I spend so much time laying down the foundations, because if you get this, it's over, baby. Okay, restrictive lung disease are divided into extrinsic and intrinsic. Extrinsic, easy. The problem could be in the thoracic wall, neuromuscular, diaphragm, or pleura. Okay, thank you. Intrinsic restrictive lung disease is the same thing as diffuse parenchymal lung disease or interstitial lung disease. This is the first type, which is parenchymal. The problem is in the interstitial space between the alveoli. Example, pulmonary fibrosis. Next, we have non-interstitial disease, and this is gonna be your nice alveolus. Let's first talk about the parenchymal lung disease in the interstitial space. You have 3 types: occupational and environmental.
Hello, guys. Can you hear me?
Yes.
Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Today we'll continue our discussion about pulmonary medicine. In previous videos we have talked about obstructive lung diseases. Today we have an introduction about restrictive lung diseases. If you get this introduction and lay this foundation, it's gonna be a piece of cake. Restrictive lung disease. My lungs are restricted from filling.
Got that
I cannot
classification
get
of
the air in.
obstructive and
Symptoms,
restrictive lung
cough
disease.
and
I think
dyspnea, also known
I have
as
done well.
SOB, which stands for
I
short
don't
of
even
breath
need to
because I do not curse. I'm
show
a
it
good guy.
again.
With that being said, now let's get started. I have never met a medical student in my life who said, "Oh, I love those restrictive